Welcome to Breast Intentions, the podcast where we take off the bra of expectations and dive into honest, empowering conversations. We're your hosts, Nadine and Cynthia, two Canadian girls who swapped snow boots for flip-flops in the Cayman Islands. This is your space to feel seen, supported, and a little less alone. So grab a cup of coffee or a glass of champagne and get ready for your weekly handful of truth, wellness, and empowerment. Welcome back to the Breast Intentions podcast. Today we're flipping the script and diving into men's midlife health because it's not just women who go through hormonal changes. We're finally talking about what many know but few discuss, that men too face significant hormonal shifts in midlife that can impact everything from mood and energy to muscle mass, libido, and overall well-being. Joining us is Dr. Mubeen, a UK-trained general practitioner with over a decade of experience and a deep passion for men's health, aging, and longevity. Known for his compassionate, patient-first approach and broad clinical expertise, Dr. Mubeen brings insight that both men and the women who care about them need to hear.
So today we have a very special episode, something that is a little bit different than our typical women in midlife, women in menopause, is men in midlife. And there's no better person to talk to about it than Dr. Mubeen, who is down here on the island.
Hello.
How are you?
Very good.
Good. Thanks for coming. So why don't we just hop into it and have you give a bit of an introduction on how you got here and how you got into what would you say is your speciality?
So I'm a UK trained GP. Before I became a GP, I had a bit of a role in general surgery, urology, obstetrics and gynecology. I delivered a baby in a car park in a car. Story for another time. Without any gloves on. And lots of pediatrics, emergency medicine. And then the hormone side of it was just something I was intrigued by. Started off with menopause after I saw what my mum went through. So I'm a big advocate of HRT. And then it was natural just to move into men's health territory, with testosterone. And that's been a big taboo subject. And more so than menopause in some ways. Men just don't talk about these things. Mm-hmm. And it's a lot more insidious than menopause. And so the more I read, the more I learned, and the more I realized how badly it's actually managed, mm-hmm. generally. So I think a lot of it's handled quite poorly, and a lot of men can end up suffering from it. Mm-hmm. So I've sort of deeper dived into it. Right. Yeah.
And what did you call it again? Andropause?
Andropause. Right. Yeah. It's technically it's not the correct phrase, and there's lots of people out there who would say it's not the same as menopause, and in some ways it's not, but in many mm-hmm. ways it is. Menopause tends to occur for the vast majority of women from about 45 onwards. Andropause is not necessarily midlife. It tends to be something that these days anyway is picked up earlier and earlier. I've seen shockingly low testosterone levels in men in their early 20s. Oh. Right? And when you imagine that they've actually just gone through their teens, right, mm-hmm. with very low testosterone, mm-hmm. That's not really having lived their teens at all. Yeah. Mm-hmm. And then when you talk to them about what their teenage years were like, what university was like, the times when you're supposed to be having the most amount of fun, right, it wasn't fun for them. It was quite sad. Mm. Yeah.
It's interesting.
So what do you contribute that to?
So if it comes to the low testosterone,
in their 20s would be rare, though, would it?
It is rare.
Okay.
Is it environmental?
So a lot of the studies are starting to show that there's a bit of an overlap with the environmental and genetics, just like with most things. You could have a gene for lung cancer. That's not going to be triggered unless you smoke, right? And then we all know of really heavy smokers who still run marathons and never have cancer. So it's never really that clear cut. But yeah, it's most of the time it's hypogonadism or testicular failure. And if I see a patient who comes in with some of the symptoms I'm sure we'll discuss, if I'm going to test their testosterone, I need, it's no good just knowing that what their testosterone levels are like. It's just as important to know why their testosterone levels could potentially be so low. Is it something because of the brain and the testicular axis, or is it to do with the hormones from the testicles themselves? Yeah. What's shutting down the production? And that would also need to be dealt with.
So then it's probably fair to say that when you are meeting with any of your patients, how long would you spend with them? Quite a bit of time, just to get to know their lifestyle? And
a new patient, I would normally give about 45 minutes.
Okay.
Easily.
And that's man or women?
Men or women. It's an interesting question because it usually, for men and women, it's usually the first time they've actually been listened to.
Yeah. Yeah.
Right? And it gets emotional.
Yeah.
It really does. You know, there are tears simply because you're being listened to, because you're not. Because the amount of times I've had men or women all come around and they'll say, I've just been to about 3 or 4 different doctors in Ireland, and they've told me that the numbers are fine, and it's in your head.
Yeah.
And who would say that? But that's literally what they've been told verbatim. You've been told it's in your head.
Yeah.
I mean, how does that make you feel?
Right.
Yeah. For some people, it stops them going any further.
Yeah, for sure.
That's scary because then you're not living, are you? You're just existing.
Yeah.
Yeah.
I think one of the cool things is that any doctor that we have had on the show have they've all switched from traditional medical over to more of like a bit of a holistic approach, but it's because they wanted to spend more time with their patients. The last one that we just had, she saw 25 or 30 patients in a day.
Yeah.
And now, I don't know how many people it is that she sees, but
it.
she spends anywhere between 60 to 90 minutes. And so that she actually has that time. Dr. Bella, I think,
they've all said the same thing, that it just, they weren't practicing the way they wanted to practice with that, the numbers, it's a numbers game.
You can't be a doctor. Exactly. So I come from the NHS in the UK. We have 10 minutes per patient.
Yep.
But realistically, we actually have 8 minutes per patient, and then 2 minutes for me to type up my notes, go outside and call the next patient in.
Right.
Nobody ever comes in.
Because that takes time too. Yeah, for sure.
And whoever comes in with just one problem, you have to look at them holistically. When I was being trained in medicine, one of the professors once said that, your job is to treat the patient, the person, not the numbers, right? And I think that's where a lot of things go wrong today in the realms of menopause and andropause. The numbers are looked at before the patient. You come in, men will come in, and they've got their symptoms, and somebody will turn around, the doctor will look at the results and say, no, you're actually well within the normal range, or you're in the normal range, or you're just in the lower end of the normal range, but it's all normal.
Right.
So there's nothing to do.
Right.
But clearly something needs to be done, right?
Right,
So,
because it's all then anecdotal, and how are you living your life and how are you feeling?
right. I have this analogy, and if any of my patients are listening, I'm sorry. They've probably heard it so many times. But you have 2 identical twin brothers, right? Both of them arbitrarily just randomly have a testosterone level of 500 each. Okay, that doesn't mean anything, but we'll just use that figure. Twin A, testosterone of 500, great sleep, great mood, great libido, responds really well to exercise, great motivation, focus, right? Twin B, identical to his brother, exactly the same level of testosterone, 500. Poor sleep, poor libido, poor response to exercise, poor focus, poor motivation, poor mood. Yeah, but the testosterone levels are exactly the same. What does that tell you? It tells you that it's not about the level, but it's how that person responds to that level. How, if that level is enough for them. And that could be said, same thing for menopause.
Yeah. Yeah, for women.
Yeah.
With this episode being all about men and midlife, their hormones, can you give us a very brief overview of the difference between men's hormones and women's hormones?
Yes, good question. I've actually seen, like, on Instagram posts and stuff, doctors will post a comment.
Yeah.
And it's like a man commenting, "Oh, great, give the woman male hormones. That's really going to help."
Right. Okay. So men have estrogen. I don't think we have enough time to go to all of it, but yeah, let's do what
Clips
both men
version.
and women have.
Okay.
Right? So you have estrogen, FSH, LH, and testosterone. Right, sex hormone, binding globulin, DHEAS, and all those. But essentially, the first four: estrogen, testosterone, FSH, LH. Those are the basic.
That both
ones.
have.
Yeah.
Okay.
Yeah. I mean, there's lots of others. Thyroid, for instance,
Right.
insulin, IGF. Yeah. But in the realms of what we're discussing,
Okay.
and just to keep it nice and simple, those are the basic things I would do. And the prolactin, which is a level from the brain. So women do not have the same range of testosterone that men will.
Right.
Yeah, so it would depend on which labs you use. It can vary from about 10 to about 20. Whereas for men, 200 to about 1200. Right.
Okay.
So there's a big difference.
Yeah, right.
But we both need
Yeah.
testosterone.
Well, same with estrogen.
We both
don't think I was
need
aware
estrogen.
that men have estrogen.
That's right.
Yeah.
Yeah. And we do need it. And hormones, if there's one thing that people take away from this, hormones all about balance, something called homeostasis, right? And I think nature in general is about homeostasis. It's about trying to keep that balance, but to keep that fine balance, well, sometimes things overswing. And if it goes too far in one direction, then the body will release another hormone to bring it back up, but then it'll be just enough to it'll go over the line again. Then
right.
So you've got this fluctuation, constant fluctuation, to try and keep everything as close to this normal baseline as possible. So we would see with testosterone replacement therapy, if at times it becomes more of an art than a science, because everybody's different. So getting the right level, that sweet spot for your patient, can sometimes take a couple of months. But if it's too high, then the body releases estrogen to counter the testosterone.
Okay.
And then men will have gynecomastia, for instance, swollen breasts and nipples, tender nipples. And whereas for women, it's kind of the other way around. But testosterone has to be a part of menopause treatment as well, right? So for HRT, hormone replacement therapy for women, is often, the testosterone is often overlooked.
Yeah.
Because it's a male hormone.
Right.
Which it's not. I mean, primarily, yes, but it's not only.
Right. Okay.
Everything has to be balanced.
Everything has to be balanced. Yeah.
And like you said, it is an art
It
as
is.
well. And I've seen clients go through it too, where, and I always say to them, you do need to go and get your bloods run like every 3 to 5 months.
Yeah.
Until at least you get some stuff that starts to stabilize, but it will never really stabilize because you're always going to have different factors that
That's
are coming
right.
in.
And our bodies are aging, and if you're already shutting down production, then you're you're not going to need the same levels you're going to need 6 months from now.
Right.
Right. So monitoring is key. That said, you find the right people to look after you. I've had guys who've been on testosterone replacement therapy 10, 15 years.
Which is TRT.
TRT.
Okay.
So the key word there is therapy. Right? So that's what we're doing. We're not making bodybuilders. Right? And I think a lot of the
misconception
stigma
around that.
and the side effects and the fears come from both for doctors and potential patients, comes from the bodybuilding world, where they
100%.
would take 10, 15 times the amount that we would give as a therapeutic level, therapeutic dose. In a week, they would take 10, 15 times that amount and then add on 3, 4 other anabolic steroids on top. So things are bound to go wrong.
Right.
Okay, so kind of focusing on testosterone.
Right.
And focusing on men.
Right.
Low testosterone. How does a guy know if he has low testosterone other than just getting labs run? Like, what are symptoms?
Okay, that's a good question. Simply because it's something we should all be watching out for and not accepting it to be just getting old. Not in this day and age, right? So the classic symptoms for men would be, and it's not in any particular order, and you don't have to have all of them. You could just have one of them or two of them. But things like poor sleep, poor focus, motivation, not responding well to exercise, finding it difficult to shift fat, low libido, all right? That said, there are lots of other factors that could also be causing this. So if somebody comes in and they'll say, I think my testosterone's low. And so why do you think that? Well, because of this, this, and this. And it's not, it would be poor form of me, poor medicine of me to just say, yeah, you know what, I think it's testosterone related. It's not necessarily, because your high blood pressure could be doing that. Your eating, your diet, your lifestyle, diabetes, smoking, thyroid is a big one, right? So all of that stuff, anemias, any of them, and sometimes something more sinister underlying. And cancers could trigger similar symptoms. So everything needs to be explored,
right,
before you say yes. This is low testosterone.
I saw that post that you had made about the red flags.
The red flags,
Yeah.
exactly. There's
That's
so
scary.
much, right? I mean,
It's the same
I
with
was trying to
women
make it
too.
informative. Exactly. Yeah. But we need to be aware of these things. And these are the things, when you go to see your doctor, these are the things that are shooting through your doctor's mind. And those are the basic ones, you know. And then, as I said before, there's a lot of overlap. And if you suddenly find that your libido suddenly dropped over the last few months, it's easy to say, oh, testosterone.
Low testosterone, yeah.
But it doesn't necessarily have to be, and it does need to be investigated.
Okay, so if someone comes in and says, I think I have low testosterone.
Okay.
So where do you start with them?
Okay. A full history.
Okay.
So listening is key, right? The golden minute, we used to call it. You just give the patient a minute and they will give you all the answers you need.
It's true.
Right? And then I would explore. So I tend to, for some reason, I always start with sleep because I think it just brings people in easy.
Yeah.
Rather than, how's your libido?
Yeah, right.
We've never met before, but how's your libido? All right. How are your erections? Oh, am I allowed to say that?
Yeah.
It's too late. Okay. But that's a question I have to ask, right? And then I often say that as a doctor, you're allowed to ask the hard questions. That's what you get paid for, really, and give the hard answers, right? So I always start with sleep. And then, you can run onto, okay, how does that affect your mood? How's your libido? because you can just link that. Are you waking up with morning erections that you used to? How are you responding to exercise? And then we would talk about the bloods, the labs, as we call them here. So I would talk through why we need to do them. It has to be a partnership. With my patients, it has to be a partnership. And this is another thing. If any of my patients are listening, they'll be like, hey, here he goes again. But it's a partnership. I'm a glorified advice giver, at the end of the day. And we peddle or could be poisons if they weren't measured and given appropriately. So I want you to work with me. I want to work with you, and I can't just throw something at you. And once you leave the room, I have no idea what you're doing,
right?
Whether you're going to do it. So unless we build that rapport, and you trust me, and I'm going to trust you, and we build that relationship, you're not going to get anywhere, and nothing's going to really work for you. So then we talk about the results. So we talk about which lab tests we're going to do and why. So that no surprises. Which lab tests will normally order? Testosterone. There's a free and there's a total. Right. The total is the amount your body produces. The free is the amount it actually uses. It's very simplified terms, because it has to go through your system, and not all of it gets used. Then we look at FSH and your follicle stimulating hormone, which is a signal from your testicles, if it were. A signal from your testicles to produce more testosterone, and prolactin, which, if it's raised, could mean that there's usually a benign tumor in the pituitary gland of the brain that's reducing the signal to your testicles. So that's why it's important to distinguish which one is before you start treatment. And both of those more than often, get overlooked when it comes to shoddy TRT treatment.
Is FSH the one where, for women, when we're getting tested, that's how we can know if we're in menopause?
Yeah.
In menopause, exactly. And I'm glad you said that. In menopause, not perimenopause.
Yeah.
All right? Because it's fluctuating. Exactly.
Yes.
So the testing for perimenopause is to make sure it's not something else. Make sure it's not your thyroid. We would measure because we want to keep a baseline.
Okay.
But it fluctuates.
Oh, okay.
You're still having your periods, although maybe erratically.
Yeah.
But the hormones are going to fluctuate, and you're trying to take a snapshot picture of somebody's blood levels of FSH, LH, progesterone, estrogen, at a time when they could all just look normal. And this is why a lot of women will come in and say, oh, but my last doctor told me that my levels are normal. But I know I'm not normal.
Yeah.
Something's wrong.
You have to go also based off the symptoms.
Treat the patient, not the numbers. Yeah.
So then, after you've established all of the labs that you're going to do, you run the labs, you get the answers, and you decide at that time kind of the prescription for them.
Yeah.
And when you're doing that, do you also prescribe diet?
So, yes. So there's a rule of thumb. Exactly. So there are a couple of things I always say. You have a spiel for everything, right? You do it often enough. And I would tell them that, look, now that you have testosterone back in your body, because sometimes men have come in and they're almost completely depleted. Now that you have testosterone again, it's like putting premium fuel in your car, but don't effing waste it. Right? Yeah. You put premium fuel in your car and then you've just parked it up. And I don't need your money that badly. Yeah, you just don't come in. There's no point if that's all you're going to do with it. We are giving you, we're resetting your life by 10 years, 15 years, 20 years sometimes. Yeah. What would you do if you could go back 10, 15, 20 years? You had the energy that you did back then. Go out and do it. Make the most of it, because isn't that what the whole point is? Right? It's the whole thing about longevity, I suppose. That falls into this sort of territory. We can't control how long you live, but we can definitely control the quality of life.
Right.
Yeah, we have that technology now.
So then what would a guy notice if they were put on TRT or, the proper protocol? What are some things that they're going to notice from that?
So it would depend on the type, but the type of therapy they receive. But usually within about 3 weeks, I ask them to come back in about 3 weeks, and so we can follow up and see how they're feeling. Everybody's slightly different.
Okay.
But everybody's like, I feel amazing. There's always that, right? Some people will come in and say, I've noticed I'm just getting stronger and faster in the gym, and I'm sleeping better, or my focus is better. Or everybody starts with, everybody caveats with that with, I don't know if it's a placebo effect, but yeah. And then my libido, my sleep, everybody's always got something from the list.
Okay.
1, 2, 3 things, but there's always something. Usually at 3 weeks, I bring them back just to make sure that they're happy and there are no sort of side effects. But then it's the 8-week mark, right? That's when we really know. And I've not had one patient, male or when it comes to HRT, female, come back and say, I wish I'd started this 10 years ago.
Yeah.
Right. It's a game changer. Done properly. And if it's appropriate, it's a game changer.
We've talked about that too, where I think it was me that had asked you if you could go back, how many years would it have been where you actually would have started HRT?
Right.
Yeah.
Yeah.
I take it.
Right.
And it was probably the best thing for me.
And how long did it take you to notice?
3 weeks.
Exactly,
yeah.
Right?
Like I've said on the podcast, and I say it to my friends too, like it's not a magic cure-all. Like it doesn't make me now feel 10 years younger. It doesn't make me suddenly not have symptoms or be like this perfect young woman again. But it helps me handle those in a completely different way. Where I do have a bit more energy. I'm sleeping well. I'm all the things. And I can't imagine not being on it right now.
Right. And then there's the testosterone side of that as well. But also
I'm going to have to look into that.
And
I'm not sure that's a part of my protocol.
Right. And that's the thing. It goes back to what I was saying at the start. I think there's this big taboo about talking about testosterone. In men, imagine how much of a taboo it is in women. Yeah. But testosterone...
Well, it's not a woman's hormone, so why would you talk about it? Yeah.
When it clearly, truly is. You need testosterone.
If that's not in my protocol, let's just say it's not, what would be the difference? What would I be missing? Like, why would I need that?
On the top of the list for testosterone for women, we're looking at libido. But then as you go down the list, it's all the usual stuff: muscle, bone health, cardiovascular health. Okay. So it's all the same as for men.
Okay.
But the top of the list would definitely be libido, and you just need such a small amount.
Like 10.
Yeah, I mean, it usually comes in a gel. That's where it would start you, and then there are other options. But just the gel. You get 1 mil, exactly. If you're 50 milligrams in a 10 mil packet, usually, so that's about 10 mils, and 10 milligrams in a mil. So a very small amount, basically.
Yeah, right. Yeah. Okay. Good to know.
And that's what I was saying at the start. You cannot have HRT if testosterone's not involved in that. Because it should be. It's not just estrogen, progesterone, FSH, and that's it.
And I think the tough part is there's so much conflicting opinions.
Right.
And I think also because everything is just very new from a menopause, like everything is just starting to to come out.
Like, especially for us, like I'm just a regular woman. I don't know what I'm supposed to advocate for. I don't necessarily know.
Yeah.
Like if your doctor says, here, take this.
That's right.
Oh, okay, great.
Yeah.
And I'm seeing it different. Like I'm happy with the results, but.
So when you're working with guys, when is there a time that you look at labs and you can see that there's deficiencies and you can see that there's symptoms that are leading into these deficiencies that you're like, actually, you're not a candidate for this? Is there ever?
Or if they don't want to, like, because women as well, like don't want to do HRT or can't for whatever reason.
Yeah.
Is that this could be the same for men?
Same for men. I had a chap I was seeing, where are we now? What day is it? Saturday. So just last week. And his levels are below where they should be for his age. Right, actually way below, just in the red, but he's happy, right? He's happy like that.
Okay.
So I don't care. I don't mind. I don't need that. I don't do that. I don't feel the need to do this or that. So why would I take it? It's a fair point.
Yeah.
Okay.
Yeah, exactly.
Yeah.
Listen to the patient. Right?
Yes, exactly. Yeah.
There's no point in me forcing it. I'm not. It's a lot of TRT, testosterone replacement therapy, and HRT should be about symptom management. That's the primary purpose of it. Yeah.
Okay.
So you're helping people feel more like themselves again. Right.
100%.
But they also have to do the work.
But they have to do the work.
Eating properly,
That's
exercise.
Right. Relationship, that's why you have to build that rapport, right? That relationship, because then you can, when they come in and
there is a big,
they haven't been looking after themselves.
Months
right?
I was like, I can't explain it. I'm just not me.
Yeah.
Like I can't give you more than that, but it's just, I'm not who I'm not me.
That phrase hits hard.
Yeah.
You'll sit in front of me and I will say the purpose of you being here, why we're going to treat you is to make you feel like you again. And it's, it is often opens up the floodgates because that's all I want, is what they say.
Yeah.
Right? Men or women, that's all I want. Men often don't even know. It's so insidious, it just so creeps up on them. They just accept, I'm just getting old.
Yeah.
Old and grumpy.
Right. Yeah.
Right. Would most of them come in, this is just out of curiosity, because of low libido or a change in erection? Or no, is that just me being stereotypical?
No.
Maybe they won't say it.
Yeah. I think
Initially.
I would say at the moment 50-50.
Oh, okay.
So 50% will come in with some sort of symptom, right? But only a very few will come in and say it's libido. But rarely is it just libido on its own. So they'll start with something else. They'll come in my sleep, my focus, right? And then I explore,
right? And
then get everything else. But the other 50%, and this number was lower, obviously, when I didn't have as many patients as I do now. But now, anecdotally, there are patients who will come in, and they'll come in because, for instance, they've just had a sprained ankle.
Something not at all related.
Nothing at all related. But I will just look at someone and I just get a feeling, that heuristic sort of approach where you've done a job often enough. Just by looking at somebody or something, that something's not quite right.
Right.
And so I will explore. Can I ask you, how's your sleep?
Yeah.
Paul, how's your libido? Oh, actually, now that you mention it. And so we just opened up a whole new chapter in their lives. It's all gone back a chapter, whichever way you want to look at it.
Do they usually come in on their own, or are they usually being sent by their partner?
Usually is a tough term. It usually is a bit too strong, but there have been several who have been sent in by their partners. And often it's women who have come in and had HRT treatment.
Oh, okay.
And are now
right.
awakened.
Yeah, they're like, this is amazing.
Right. And
Go chat
they're
to
like,
this guy.
Well, they're not matching anymore.
That's exactly
Right.
that.
Yeah.
Exactly that. You
Right.
just see it all of a sudden, right? And it's like, Dr. Mubeen, look, my libido is fantastic now. Can you get my husband to catch up?
Right.
Right. So yes, I can.
You're out there saving marriages, I'm sure.
Right. That wouldn't be the first time I've heard that. Actually.
Yeah,
Some
for
people do
sure.
say that. So
Yeah.
maybe.
Yeah.
Oh, well, like we've talked about this before too. And I think we'll talk about it more on another episode. But the divorce rate increases during midlife for whatever reason.
Yeah. All of the above.
All of the above. Exactly.
Yeah.
Yeah. With the testing as well, we were just talking about this in a previous episode. When you're doing the blood work on a male, we were seeing that like the correlation of cholesterol
Okay.
for a female
Right.
can go up
Yeah.
greatly when there is a loss in estrogen. Yeah.
decrease in
Is it the
estrogen, yeah.
same in guys? Like the cholesterol can be affected?
Yes. Again, short answer, yes. Long answer, bit more complicated. So it's not so black and white. You know? It goes back to, as you were saying, you have to exercise. You've got testosterone. If you get too much testosterone in your body for too long, it actually can increase how you store cholesterol. But also testosterone can increase your appetite. So you're eating more.
Oh, okay.
And you...
It's kind of indirectly then?
You're right.
Okay.
Yeah. There are certain responders, certain patients who will respond to testosterone by storing more LDL, bad cholesterol, or triglycerides. There are some, it's actually extremely rare, but some men whose prostates will enlarge because of testosterone. Although I've not seen one, and the studies are actually kind of moving away from that theory, but it's still a test we do just in case.
Do you do the genetic test for that one? Because there is, I think it's the testosterone to DHT.
Okay, right. Yeah,
That
so
affects the
we
prostate?
don't. I mean,
Okay.
it's expensive and it changes nothing.
That's
right?
true.
Yeah.
Yeah.
So why do it?
Yeah.
That's, this
then
is
would
my
you-
NHS thinking, you see. Like I could justify, I don't know, maybe doing an MRI of the testicles as well. But actually, it
So
makes
do you just pull them off of the testosterone?
It depends on what sort of levels they're getting at and what the estrogen is looking like. And we may take a break for a little while and see how quickly they come back down. We may just need to add in something to bring the estrogen down. So yeah, it becomes more of an
It's a
art
puzzle,
than a
isn't it?
science.
Or- yeah.
You mentioned a few times, and I wanted to answer that. So I will say to my patients that now that you're on testosterone, or you're an HRT, but testosterone, in this case, that two things you have to do. Weight-bearing exercise, right? Because that is the key to longevity, right? Just running isn't enough. Weight-bearing exercise. If your muscles become denser, they burn off more calories, more fat, whatever, however you want to look at it, at rest. All right, so you're burning more calories. You're healthy even just sitting there, because your muscle quality and density means that it needs more nutrients. And the denser your muscles are, the denser your bones are. Right, so there's bone protection, and obviously there's the cardiovascular side to it. And then the other thing I would say, your protein intake needs to be a priority. Not necessarily increase your protein intake, but make protein your priority. It should be about 70 to 80% of your diet as we get older. So the way I usually sell that is, you don't need to be taking extra protein shakes or anything, but if you have a plate in front of you with steak and chips and fries, whatever you want to call them, and vegetables, and you start with the steak and the vegetables. And if you've still got room, you move on to the chips.
Okay.
Right.
I mean, for women, there's the risk of the bone density. Like
Yep.
that. Is that the same for men?
Yep.
Ah.
Yeah.
Do you just not see it as much?
So as I say, so the drop off in female hormones after 45 is
Like going off a
sheer.
cliff. Yeah. Right.
Yeah. And
Oh, we know.
right? You're
Yeah.
45 and 44, everything's all right. 45, 46, oh my God, what just happened?
Right.
You know, so, you know,
I got a year.
right?
Oh, buckle up.
There's some women come in, I'm like, 6 months ago, I was great.
Oh.
Who am I now? I don't know who I am. Men, no, it's a lot more, it's a slow burner. So they still have some testosterone and they put on weight and the weight can increase bone density. But there's the quality of bone eventually does disintegrate. The problem with that is that if you fall, you're more likely to break a bone. If you break a bone, especially as you're older and you can't get up,
Yeah.
that's that's problematic.
Right.
And then if you do end up in hospital with, let's say, most elderly people end up in hospitals with hip fractures.
They don't come out.
Or even if they do, you're looking at between 2 to 5 years
Yeah.
survival mortality rate after that.
That's men and women.
Men and
Women, I think, is even less.
Women
isn't it?
it's worse for women.
Okay.
Yeah.
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 Get
Sad.
your hormones tested. Right. There's no. You don't have to wait for any sort of particular
And-
sign.
I also am huge on people getting their hormones tested even when they feel great and even when they're younger.
Yeah.
To use it as a baseline.
Baseline.
And
yeah.
follow it. I don't even remember how long ago I started getting my hormones tested. And I usually do it every 6 months
Okay.
just to see. And
Yeah.
obviously now I'm a lot more diligent with it just to watch everything. But one of the other things that I wanted to ask you is whether it's HRT or TRT, do you believe in people stopping after a certain time? Because that's a big conversation as well right now.
Yeah. So it doesn't have to be stopped. All right.
And that's a myth, I guess, because
Yeah.
or old school thinking, I suppose, from old studies.
Yeah.
Didn't they say like women 5 years or something?
I don't even think it's that long.
Yeah, they do it 5 years after menopause.
Oh.
Right. So not just 5 years.
Period.
You've had your 5 years of fun.
Yeah, get off.
Get off now. Yeah, give somebody else a chance, right?
Right.
And then you just go back to feeling crappy
Yeah.
again. No. It's 5 years after full-blown menopause. And
How do you know when that is?
I was just going to say, even then you won't know when that actually is.
Okay.
So the cutoff is usually something like between 51 and 55 years old, all right? Depending on when you started as well. And then you come off and then see what happens. If symptoms return, if they're exactly the same, you go back on. If they're much, much milder, you have a half a dose, quarter dose, whatever.
Is there an age for a woman where you're like, no?
No, because it's about symptom control primarily.
Okay.
Right. So if you feel like crap, that's not
Even if
living.
you're 70.
Even if you're 70, yeah, that's not living, right? Then it's unfair. What if we reverse the question, is it fair on a 70-year-old to not give them HRT if they feel as awful as a 45-year-old does perimenopausally or menopausally?
So then what about guys for TRT?
If a man that doesn't want to go on TRT,
It's even better for men.
can we boost testosterone?
So they can go
Easier.
longer.
They can go for longer. Yeah, definitely.
Cynthia now works for you.
Can we boost testosterone without taking testosterone?
No, not really. If you had the best sleep, the best diet, best workout routine,
No stress.
and no stress, and your testosterone levels are low, then given if everything was perfect, you could maybe fractionally increase your testosterone naturally. But on the whole, no. I will also add to that there are no known over-the-counter treatments, all right, that you can buy that will naturally increase your testosterone.
Right. Because at the vitamin shop, they might be selling something.
They have
they must hate me.
Muscle Tech, I think, used to have a testosterone booster. Or something.
Lots of them.
I think
am I allowed to say GNC? Okay. Yeah. So, there's lots of them out there.
There is.
Right.
Yeah.
So I have a rule of thumb that if you can buy it from Amazon, it's almost certainly not going to work. Right. Because if it did work, it would be regulated. It would have. You don't know what you're getting. Just because something is natural doesn't mean it's safe. You
That's
don't.
A good point.
Yeah. You don't know. Everybody could have the same amount of, I don't know, fenugreek. You could buy 3 different brands if you like. And they could all say they've got 100 milligrams in each. But you don't know what the quality of it is.
Right.
And you don't know what the stabilizer or the filler is. And there's so much that doesn't need to be labeled. It doesn't need to be mentioned. Yeah. But studies, I'm evidence-based. I want to see a study that's looked, or studies that have looked at hundreds of other studies that have looked at hundreds of treatments on thousands of people to come up with a number that works or doesn't work, right? And no, the natural stuff, the over-the-counter stuff, none of it works. And unfortunately, or perhaps fortunately in some ways, a lot of mostly guys will come in having spent thousands on buying over-the-counter stuff before they come and actually see a doctor, before they realise that it's not working.
That's probably part of the taboo part of it too. Like they would rather, I'm just going to try this on my own.
And it's easier, right?
Yeah.
At least you think it's easy. Just pop a pill and it's done. Yeah. It's a hassle. Guys are busy.
Right.
Do you find as well that with guys, with regards to TRT, where I can see this sometimes with the mindset around the HRT for women, is they're like, oh no, I don't want to go on medication. Where it's the misconception that it's called a medication. Like it's actually like you can't get that back.
Right.
You can't get those hormones
That's
back.
right.
So it's more of a support.
Look at it as like a supplement almost, it's a replacement.
Of what our body made.
But doesn't
when we were younger. Yeah.
That's right.
Okay.
Yeah. And also if you could be insufficient or you could be deficient, right? Insufficient would be that you're on the lower end for your age. Or you could be deficient, which is you just gone below the threshold. Whatever replacement you have, you are in control. That's another thing I often say. You're in control of your treatment. If one day you don't want to take it anymore, you've had enough, you just come in and say, you know what, Doc, thank you for everything, but I'm done.
Do you have to cycle off?
No.
It's not like the bodybuilding days?
No. Yeah. You don't really, not with the levels we use, again, nowhere near bodybuilding levels at all.
Okay.
Yeah.
I actually heard something the other day. It was on Instagram.
So it must be true.
Yeah, exactly. Yeah. But someone was saying that, yeah. I actually heard something the other day. It was on Instagram.
So it must be true.
Yeah, exactly. Yeah. But someone was saying that the levels of hormones in birth control is far more than the levels that are in HRT.
Yes. Yeah. Yes. Again,
is that true?
Short answer. Yeah. We could turn that around, and HRT is not contraception.
Yeah, they're different drugs.
Right?
Yeah, you're right. Okay.
So there's estrogen and progesterone. Only if you have a uterus, you need the progesterone aspect of it. But
why is that? I've heard that so many times. Why?
So unopposed estrogen increases the risk of cancers in the uterus, uterine
Okay.
cancer, endometrial cancer.
If you just take
If you just take
estrogen without the progesterone.
without the progesterone.
Okay.
Yeah. So going back to what you're saying, so the levels are lower. You just need a small amount, but it's way below enough to be a contraceptive dose.
It was probably in response to somebody saying like, HRT, that's taking hormones, and that's not healthy.
It's so bad.
It's so bad for you.
Yeah.
And then they probably said, well, birth control pills have more
That's
hormones.
right.
Yeah.
Right.
Yeah. But also, these are hormones you've had your whole life up until this point.
Right.
All we're doing is replacing
Right.
them. We're not just. It's not like you're suddenly getting something brand new you've never had.
Yeah.
And that's the reason why I wanted to ask, because I do think that there is a big misconception that people are just being put on a medication, and that's not what it is. I don't know if guys have the same thought pattern on that, but I know that it's very common for women. Like, they don't want to go down the route of taking medication. Like, it's not.
Yeah.
It's not.
But people say that all the
same
time. Yeah. I'm not that person who takes medication.
Right. Yeah.
I think there'd be a lot of very, very rich doctors out there if they got a quid for a pound, I don't know, $1 for every time a patient came in and said, "I'm not the type of person who takes medication." Right?
Oh, okay. So you hear it a lot.
We hear it a lot.
Okay.
And the answer is that good, you shouldn't be.
Right.
Right.
That's not what this is.
But yeah, exactly.
Yeah.
But if you need something, you need it.
Yeah. Yeah,
if you were bleeding, you would have to put a bandage on. Would you be the sort of person who doesn't take bandages, use bandages? if you broke a bone, would you be the sort of person who doesn't use a crutch? And then that's all they are at the end of the day, the crutches, right? HRT, TRT, antibiotics, whatever, painkillers. Maybe not antibiotics, but painkillers. They're a crutch. You use them for as long as you need them. And then you don't have to use them anymore. It's not for life. That's up to you.
Right.
Is there anything promising on the horizon, like new therapies that could change how we approach men's health and hormones in the next 5 to 10 years?
Yeah. So how we deliver TRT is, that's changing.
How do you give it to men?
So injections.
Okay.
All right. Well,
Is it pills?
there are three options. Actually, let's make it even simpler. There are two options: invasive and non-invasive. All right. So invasive is things like injections and pellets, which are a new thing.
Oh, for guys.
Yeah.
Okay.
So just under the skin. So those are the invasive things. And then you've got the non-invasive, which is a tablet. That's it. There's only the one. Or it's isomer, as in there's another type. It's more or less the same thing. Now, that can help. It doesn't actually give you any extra testosterone. It encourages your testicles to produce more testosterone. Yeah, right? But if you're already shutting down and you're encouraging your testicles to produce more testosterone, the quality of the testosterone doesn't necessarily have to match up. Yeah, it's still going to be poor quality testosterone. You can equate it to when women have ovarian failure and a difficulty becoming pregnant, and then those last few eggs, you can have follicle stimulating hormone artificially to try and induce the release of more eggs, but because they're already shutting down, the quality of those eggs is not going to be the same as it was a few years ago.
Okay.
Right? So some people argue that the tablet, although it might increase the number on the lab result, that your testosterone level's gone up, I will anecdotally admit that most of the men I put on tablet don't experience the same level of changes, if any, compared to the cohort who actually have the injections or the pellets.
Is that because it's being ingested as well?
No, because we're not actually giving you, with the tablet, you're not being given, there's no exogenous testosterone. You're not being given any testosterone. You're just having your testicles encouraged to produce more,
I
almost
see.
recycle some of their old testosterone. And there's
Wake up.
a very
Come on.
lay way
There's
of
more. Yeah.
describing it, but and I was reading something. It basically says that the quality isn't the same because you're already shutting down.
Right.
So you're already producing poor quality testosterone, so you're not really going to get that much from it.
Okay.
But the shot or the pellets will give you more testosterone.
It gives you testosterone. It actually gives you testosterone
Okay.
rather than just encouraging you to make some more of your own.
Okay.
A question about the pellets, though. Do you tend to go for the pellets initially, like first?
No.
You wait until you
Yeah.
build to where they need to be?
Exactly.
Okay.
So you see what somebody needs, and also it might not be their cup of tea. They
Yeah.
might get off after 8 weeks and be like, you know what, it's not for me.
And then you can.
Yeah, you're like, well, too late.
Yeah, exactly.
6 months, you'll have to just ride this one out.
Yeah.
Yeah, there's no getting out afterwards. So sometimes people will say, oh, okay, can we just jump straight to the pellets? And we're like, well, let's just find out what your sweet spot is
Right.
first, if how much you need, how much is enough for you. Sometimes you just need a microdose, but sometimes you need a little bit more. But we need to figure that out, and that can take a few cycles.
Okay.
Are there side effects or negative consequences, I guess?
Yes.
To this?
Yeah. Just like any medication, just like water, just like this empty glass. Champagne, right? But so the hundreds we've treated, I've only seen one patient with side effects, touch wood, and he just had some hot flushing, or his skin became quite flushed and red. So he was over responding to the low levels of testosterone given, so we reduced it and everything was fine.
Okay.
Right? The whole stigma, the whole reason why a lot of doctors are afraid to partake in TRT and you actually consider it as therapy is because the side effect profile that we still think about actually comes from the bodybuilding world.
Oh, okay.
Where they, as I said, they take 10, 15 times the amount of what we would give as a therapeutic dose. But then they don't just take one steroid, such as testosterone, they would take several others, all in the same weeks. It's called stacking. So they will do several different things.
Right.
And that will mess you up.
Right.
The long-term side effects of having high dose testosterone in a lot of men is that you can reduce sperm count. And so that's a conversation I will have.
Oh, if guys are wanting to have children.
That's right. Have you completed your family? That's the question. Or when do you think you'd want to? So you need to have that conversation. It's nice when a guy comes in and says, I've had a vasectomy. All right, let's get going.
Right.
Or they're like, no, two and done, mate, two and done.
Yeah.
Yeah, that's it, they're happy.
And possibly by mid-age, like we're talking about midlife.
That's right, yeah. And
Presumably.
not everybody wants children, right?
Right.
And so that's something else as well.
If you could give one piece of advice to men in their 40s or 50s about their health and hormones, what would it be?
Don't wait until you're in your 40s and 50s to start thinking about your hormone health. There's a difference between living and existing, right? And we should be living, right? You may not know, and often for men they don't know that they're deficient because it's just crept up.
Right.
I'm just getting old. That's it. I'm in my 50s now. I'm just no.
And you might not know that you don't have to live that way.
Exactly. Until you don't know what you don't know,
Yeah.
right? And then you sort of like you start treatment for a while. Sometimes, rarely, but sometimes, if a patient's umming and ahhing, I would say, look, why don't you just try it because I know they need it.
Right.
But I'm not going to push it. But I will say, why don't you try it? 2 months. If you don't like it, if it hasn't changed anything for you, if it's not your cup of tea, walk away.
Right.
No, nothing is going to change. Your testicles aren't going to fall off.
Right.
You're not going to suddenly stop producing any of your natural testosterone. You'll just go back to where you should be at that stage in your life. That's it.
So it's relatively easy to go on and off it, I suppose.
Yes, relatively. I mean, it should be monitored and etc. It is. It's straightforward-ish. Yeah.
Is there anyone that you won't put on TRT in terms of like their lifestyle or things that they're doing, or that's going to contribute to
people on really high, people who have high levels of cholesterol.
Okay.
People who have untreated prostate cancer, or
so you do all the prostate screening?
Oh
before?
yeah, definitely. Men with quite severe BPH, prostatic hypertrophy, enlarged prostates.
Okay.
But then there are certain types of people with certain types of anemias, because it can increase your red blood cell count as well, so it increases the risk of clotting. Oh. So yeah, there are lines that shouldn't be crossed. We can try different things, but yeah.
So then, if a person has high cholesterol, do you treat them for the high cholesterol first?
Yeah,
and then
it has to be a part of it. Yeah, well, it has to be extremely high cholesterol, threateningly high, and we need to deal with that before. Or if your blood pressure is ridiculous, or your thyroid is poorly controlled, or your diabetes is poorly controlled, then we actually need to deal with all that first. If the engine's not working, there's no point in putting on nice new wheels. Right?
Yeah.
I think that's an appropriate analogy, right? Yeah. I make them up as I go along.
So then with TRT, can you also take it when you're taking medication? For different, blood pressure medication, cholesterol medication?
Yeah, for sure.
It's fine. It doesn't interfere.
Yeah, no, it can, again, depending on the type of person you are, you might respond, your cholesterol might respond in a particular way to testosterone, but not everybody does. So those guys need to be monitored. But we need to make sure that your cardiovascular risk factors, your cholesterols, and your prostate, and your hematocrits, and all these things are actually in a safe zone before we start anything. Yeah. Otherwise, you're just going in blind and you don't know what's going to happen. 45-minute sessions don't tend to last 45 minutes. They tend to go on. But we've also overlapped with how actually it can affect and impact on women. And then we've gone a step further and said how this can impact on relationships. Yeah. Right? So, yeah, I just thank you guys. Right.
Well, it was so good to have you on, because I think our listeners are female listeners, and if there's anything that they can learn from this, so that they can talk to their partner or they can send their partner in, but we're also hoping that there's going to be men that are going to listen in as well and get to understand what TRT is and get to understand what you do, and maybe the symptoms that they have, that they actually don't need to leave it and chalk it up to getting old.
And don't be scared of coming in, right?
Exactly.
You're not going to walk in through the door and I'm waiting there with a needle and gloves on. It's not. Come in and have a chat. That's it. There's no obligations. You come in, we'll talk. I'll tell you, I'll impart the best of my knowledge to you, and then you can weigh it up, and that's it. Just come in for a talk. No misconceptions, no conceptions about having to come in and be treated or have your bloods taken straight away. There's none of that.
Right.
Just come in and talk. That's it.
Let me ask you another question. Is this tend to be covered under insurance?
Yes.
It does.
Short answer. Yeah.
Okay.
Really?
Mostly.
That's good to know. That's good.
Is it the same for women?
Yeah.
For HRT?
I mean, mine is.
Yes. Yeah.
Okay. It's good to know.
Mine is, at least here on the island. How can people find you if they want to come see you and have a chat?
You can reach out to me on Instagram, and I always respond. And but Grand Harbour Medical Centre over, it's Grand Harbour?
In Grand Harbour,
Yeah.
There you go. Yeah, did next to Hurley's.
What's your Instagram? Do you know? We'll link it.
Mubeen,
I think so.
I think. Or, yeah, something like that. K-Doc or yeah, I don't know.
Okay.
I've never had to send
We'll
myself.
put it in our show notes anyway.
But reach out. I don't mind people reaching out and asking, but everybody has always got questions, and so I'm happy to answer. There's a lot of fear out there. I mean, in some ways, that's fair. You know, fear drives us to seek answers, and that's good. But also, sometimes it goes a little too far.
Yeah.
Stops us actually getting any help.
Right.
Oh, completely. Yep. Well, thank you.
Thank you.
Thank you.
Thank you for all those really good questions.
Yes, thank you so much. Thanks for joining us on Breast Intentions. We hope you felt seen, supported, and maybe had a few laughs along the way. Don't forget to share, subscribe, rate, and review us. Your support keeps the conversation alive. Follow us on social media for more insights, behind-the-scenes fun, and updates on future episodes. Got a topic you want us to dive into? We'd love to hear from you. Remember, life's too short for bad bras, toxic relationships, and kale you don't actually like. So until next time, stay bold and keep your breast intentions exactly where they belong, front and center. Now go crush midlife, or at least today's to-do list. Cheers!